Let's kick off today's episode by breaking down acid-base balance, a core concept in clinical medicine. Dr. Carter, could you walk us through the key lab values we monitor and why they matter so much?
Absolutely. The three main lab values are pH 7.35, 7.45, CO2 3545 mmHg, and HCO3 or bicarbonate 2226 mEq/L. Any deviation can signal acidosis or alkalosis, impacting patient stability. Think of them like the vital signs of a patient's internal chemistry.
That's helpful. I often hear students struggle with distinguishing metabolic from respiratory issues. Is there an easy rule clinicians use to tell them apart?
Yes, the rule of the bees is a classic. If pH and bicarb move in the same direction, it's metabolic. If not, it's respiratory. For example, if both pH and HCO3 drop, that's metabolic acidosis. If pH drops but HCO3 is normal and CO2 rises, think respiratory acidosis.
Great analogy. And what about potassium? Does it follow the same logic in acid-base shifts?
Actually, potassium does the opposite. For example, acidosis causes hyperkalemia, while alkalosis leads to hypokalemia. It's a critical detail because it drives treatment priorities, especially in emergencies.
Transitioning to respiratory support, ventilators are life-saving but can be intimidating. What's the practical approach to handling ventilator alarms, especially high and low pressure ones?
High-pressure alarms signal resistance. Think obstructions like tubing kinks, water in the tube, or mucus plugs. The stepwise approach is to check for kinks, clear water, ask the patient to cough, and suction only if necessary. Low-pressure alarms, on the other hand, usually mean disconnection, so immediately check all connections.
That systematic approach avoids panic. How do ventilator settings impact acid-base status, and when should we worry about weaning a patient?
Overventilating causes respiratory alkalosis. Underventilating leads to acidosis. If a patient's ABGs reveal acidosis before a planned wean, it's a red flag they're not ready. It's crucial to advocate for patient safety and update the physician promptly.
Let's pivot now to addiction care. Denial and manipulation are often major hurdles for both patients and families. Can you elaborate on how clinicians distinguish between denial, dependency, and manipulation?
Sure. Denial is refusing to acknowledge a problem, most common in substance abuse. Dependency is when the abuser relies on someone else to enable their behavior, while codependency is when the enabler's self-esteem depends on helping. Manipulation is more dangerous. It's when the abuser gets someone to do something harmful, like buying alcohol for them.
How should healthcare professionals respond differently to each scenario?
With denial, confrontation with facts is key, gently but firmly. For dependency, teach limit setting. Manipulation demands firm boundaries and consistent enforcement, since the safety of both parties can be at risk.
Staying on the topic of alcohol, Wernicke-Korsakoff syndrome is frequently tested. What are its hallmark symptoms and best management strategies?
This syndrome results from thiamine, vitamin bone, deficiency, leading to memory loss, and confabulation. Patients fabricate stories they believe are true. The condition is preventable and arrestable with thiamine, but is often irreversible if not treated early. The best approach is to redirect confabulations and never challenge them directly.
And for family education, how do you explain the risk of progression and the importance of supplementation?
I explain that consistent bone intake prevents further brain injury. Families should know that while symptoms can stabilize, 70% of cases are irreversible, so early intervention is vital.
Drug toxicity cases are common in acute care. How do you differentiate between an overdose or withdrawal of stimulants, uppers versus depressants, downers?
The key is symptom direction. Uppers like cocaine or meth cause everything to go up: restlessness, seizures, tachycardia. Downers like opioids slow everything down: lethargy, respiratory depression. Overdose is too much of the drug's effect. Withdrawal is the opposite. For instance, an upper overdose can cause seizures, while withdrawal from a downer can cause respiratory arrest.
So the nursing priorities shift based on the scenario?
Exactly. For upper overdoses or downer withdrawals, seizure precautions and suctioning are top priorities. For upper withdrawal or downer overdose, airway and ventilation take precedence. Recognizing this guides immediate interventions.
Let's dig into aminoglycosides, the so-called big guns of antibiotics. When are they indicated, and what unique monitoring do they require?
Aminoglycosides like gentamicin and vancomycin are reserved for severe gram-negative infections, think septic shock or TB. Their narrow therapeutic window means we must monitor for ototoxicity, hearing loss, tinnitus, and nephrotoxicity, elevated creatinine. We measure trough and peak levels, trough before the next dose, peak after administration, with timing depending on the route.
What's the significance of these levels in practice?
Proper monitoring prevents organ damage while ensuring efficacy. For example, peaks that are too high risk toxicity, while troughs that are too low mean the drug isn't effective. This balance is especially crucial with IV dosing.
Switching gears to mental health assessment is key. How do you distinguish between psychotic and non-psychotic presentations, and why does it matter?
Non-psychotic patients are reality-based and use insight, so classic therapeutic communication applies reflection, clarification, and support. Psychotic patients lack insight and may experience delusions, hallucinations, or illusions. The care plan, legal implications, and even safety measures depend on this distinction.
That makes sense. Could you illustrate how approaches differ with a brief example?
Certainly. For a non-psychotic patient anxious about surgery, we use reassurance and information. For a psychotic patient with paranoid delusions, we acknowledge feelings, present reality without confrontation, set limits, and enforce them as needed.
Let's now talk about diabetes, both mellitus and insipidus. Could you clarify the pathophysiology and clinical differences, especially for new nurses?
Diabetes mellitus is a disorder of glucose metabolism, either insulin deficiency, type 1, or resistance, type 2. Diabetes insipidus, on the other hand, is all about fluid balance. It's caused by low ADH, leading to massive urine output and dehydration, but not high blood sugar. SIADH is the opposite: fluid retention, low urine output, and often low sodium.
How does this impact nursing interventions and monitoring?
For DM, monitor blood glucose and educate on insulin, diet, and exercise. In DI or SIADH, fluid assessment is critical. Watch for dehydration or overload. Check urine-specific gravity and tailor interventions accordingly.
Electrolyte disturbances can be subtle but critical. Can you break down the cardinal rules for potassium, calcium, and sodium imbalances?
Absolutely! Potassium follows the prefix hyperkalemia, means increased excitability, spasticity, diarrhea, except for heart rate and urine output, which go down. Calcium and magnesium do the opposite of the prefix hypocalcemia, means twitchy muscles, while hypercalcemia causes sluggishness. Sodium is tied to fluid status. Hypernatremia is dehydration. Hyponatremia is overload.
What are the high-stakes interventions, especially for hyperkalemia?
Never push IV potassium. For hyperkalemia, give D5W with insulin to shift potassium into cells quickly and use kayexalate for long-term removal. Always monitor cardiac status closely, as arrhythmias can be rapidly fatal.
Endocrine emergencies are a must-know. What distinguishes hyperthyroid and hypothyroid states, and what are the acute crises to watch for?
Hyperthyroidism, think hypermetabolism, presents with weight loss, tachycardia, and heat intolerance. The crisis is thyroid storm, extreme fever, delirium, and hypertension, requiring cooling and high-flow oxygen. Hypothyroidism is the opposite: weight gain, bradycardia, cold intolerance, and the danger is myxedema coma, demanding prompt thyroid hormone replacement and avoidance of sedatives.
And for adrenal cortex issues like Addison's and Cushing's, what tips can you offer?
Addison's is steroid deficiency. Patients can't handle stress and risk shock in crises, so give steroids. Cushing's is excess steroids, so watch for infection, hyperglycemia, and fluid retention. Treatment often involves surgery, with careful hormonal titration afterward.
Before we wrap up, let's talk about mobility aids. What's the best way to measure and teach use of crutches, canes, and walkers?
Crutches should fit with 2-3 finger widths below the axilla and the tip 6 inches lateral and in front of the foot. Teach the right gait. 2 point for mild bilateral issues. 3 point for single leg weight bearing. 4 point for severe bilateral weakness. and swing through for non-weight bearing.